Okay, great. Okay, sounds very good. So thank you for attending this, and welcome everybody to this session. Now, I gave this talk 3 times,
Just
and
start recording. Please start recording.
am I recording? Yeah, I am recording. Yeah, I am recording. And now I on the YouTube too. Okay, so the reason why I am repeating this topic is more than one actually. The first one, when I gave these talks, it was always limited time, so I don't reach the end. So only I give the introduction, and then I don't have time to finish the specific situations and conditions that feeding tips really make difference. The second reason is when I gave the talk first time was very limited number. And the third reason, whenever I give this talk, I got lots of questions by emails about different topics. So the talk is a little bit long, and I hope I will divide it in 2 phases. The first one, most of you heard it, or some of you at least heard it. But the important is the end of the talk. The reason, but the end of talk depending on the beginning. So I'm gonna repeat the feeding tips in general first, and then I will go to the specific situation of infant of diabetic mother, of NEC, of gastroesophageal reflux, of anemia, and so on. So the objectives then is we'll talk about early enteral feeding, about MEF, about fortification, donor breast milk, preterm formula, term formula, special formula, high caloric formula, supplements, feeding methods, and then we'll go to these special neonatal conditions. So all of us knows that the structural and functional integrity of the bowel depend on provision of enteral feeding. Otherwise, we will have fasting enteropathy. So luminal starvation causes bacterial translocation, and then this will lead to flattening of the villi. It will lead also flattening of lead to mucosal thinning, not thinking, spelling error. The flattening of the villi causes shortening of transition time because the villi make the bowel longer and longer. The surface of the bowel become longer and longer, and flattening of the villi make it a little bit shorter, the surface shorter, and therefore the transition time is shorter. Then what is minimal enteral feeding, or MEF, or gut priming, or trophic feeding? Name it in a way you want. The first one, it is a gift. It's not considered within the TFI, or total fluid intake, and is not considered within the calorie calculation. It is a gift, and it's up to 20 ml per kg per day. It can range from 10 to 20, but don't exceed 20. The second, it is, as I said, it's not for a nutritional delivery. And the third, it is very small volume, and it's better to be a human milk, but it can be a formula. And it preserve the gut maturation and prevent starvational enteropathy. Now, it is always very hard to say what is actually optimal volume of minimal enteral feeding. What is the benefit? It stimulates gut hormone. It decreases the chance of feeding No sound? Do you guys hear me?
I think yes, we can hear you.
Okay, great. So if you can answer people asking questions, that would be great. So when it causes, always I'm getting cut and then I have to reload. So it stimulates the gut hormone. It causes less feeding intolerance. And the time from starting feeding to full feed, it becomes shorter. It improves the weight gain, and it improves the metabolism of calcium and phosphate. And because of all that, you'll have a shorter duration of being on parenteral nutrition. We are here, we didn't say total, because obviously we are feeding in addition to the TPN. So when we start minimal enteral feeding, the earlier the better. So I am very aggressive in this scenario, and I love to start feeding at the delivery room, unless the bowel are compromised from resuscitation. It's always when you start gut priming or minimal enteral feeding, use full strength colostrum, or use preterm EBM, or use DBM. If you don't have all that, use full strength term formula or 20 kilocal formula. Do not use preterm 24 kilocal formula for gut priming. That will be too much on the bowel. You can use either fixed dose, such as 0.5 ml Q4H, for example, for babies 800 grams and less, or you can use a flexible, and you say, well, I'm going to choose 10 ml per kg per day and divide it 8 hours or Q6 aliquots or 8 aliquots. That's mean Q4 or Q3H for babies less than 1250 grams at birth. When the minimal enteral feeding is indicated, you sir, leave the question at the end, Mr. Chandra. If you leave the question to the end, we will talk about the ethical issues of using formula. So when the gut priming is indicated? Well, for all babies who's less than 1500 grams. For all babies who are less than 27 weeks. If you have severe hemodynamic instability, if you suspect or confirm NEC. Now some people ask me, but in NEC we do MPO. No, here we're talking about recovering from NEC, not giving feed during NEC. So if you have suspected or confirmed NEC and then it's resolved for 7 days or 10 days MPO and antibiotics and so on, or surgery, after resuming feed, you start to prime the gut. So it does not mean that you give minimal enteral feeding during NEC. When you have clear evidence of ileus, or you have some clinical signs of intestinal pathology. When you treat clinically significant PDA, now this it depends who's treating. So this discretion of the team should be. Now UAC and UVC will not increase the risk of NEC, and therefore both are not in contraindication of MEF. However, some of the indication for using UAC might be a contraindication for MEF. So, and then we will move, now we finish with priming the gut, now we will move how to fortify human milk. Now we know the human milk can be given either direct breastfeeding, or we give it as a EBM for term baby. However, for preterm baby, as we know that EBM in the first 21 days of a lady with a premature delivery will be premature EBM, and about 21 days will be converted to mature EBM. And therefore, EBM of premature or mature, even the premature EBM for premature baby is not enough. Although the premature EBM has high protein, high phosphorus, but even though it's not enough. So in both situations, fortification of the EBM for premature babies are required sometime. And some people will say, well, I've faced this question in some of the conferences, say, well, does God don't know what to do? Well, my reply was, I'm not a clergy, and maybe we can ask a religious man in this. But the evidence say, when we don't give fortification to human milk, the growth is not optimal. Because the baby need more protein, more phosphate, and more calories to have facing this difficult time and doing catch-up growth. We know, and the reason for fortification actually is forcing the breast milk, because we know human milk offers many nutritional and non-nutritional advantages. We know it's better feeding tolerance, we know less sepsis, we know less neck, we know there is less in general, better fighting. We know with breast milk we have earlier discharge. And we know that human milk has better sodium, better protein, chloride, magnesium. However, despite all of that, even in the first 21 days, the breast milk of premature ladies are not optimal. Not because it's not enough, but these babies are suffering too much, and they need protein and allergy, and they need to do a catch-up growth. Even when the premature EBM turn to premature around 21 days of lactation, still needs fortification. The reason, the composition varies between winter and summer, between day and night, between different ethnicities. And therefore, the human EBM, all for preterm babies, are always enriched with the human milk fortifier. Now, the human milk fortifier are recommended for all babies less than 1500 grams at birth. And you might consider it between 15 and 2000 grams. You may consider it also for those less than 34 weeks of gestation. What are the available type? Then we have powder, we have liquid, and we have bovine milk based human milk fortifier. But also we have liquid donor breast milk fortifier, and now we have a cream on the skin that we can apply it. The human milk fortification can provide up to 4 calories for each ounce, or 28 milk. If you mute yourself, please, that will be grateful. Now, the problem when you fortify the human milk, the feeding tube might get blocked. So you need to. And therefore, when you fortify the human milk, you need to. When you fortify the human milk, and because of the risk of blocking the tube, you need to give small, frequent bolus feeding. When we say bolus feeding, we're talking about feeding less than 20 minutes. That's the meaning of bolus. It doesn't mean that you smash the baby with the milk. So if you can kindly mute yourself. When we give small and frequent boluses, we will improve the nutrient delivery, and we will have better absorption. And we should have If you can kindly mute yourself, yeah, Dr. Basta. Yeah, Dr. Anibal, please mute yourself. Dr. Arula, can you mute everybody? A protocol for collect protocol for collection and storage of human milk to meet the nutritional and physiological need of the preterm baby should be available in each NICU. What are the benefits of donor breast milk? Well, despite the religious thing around it, it decreases. We know that breast milk is the best, and we know that sometimes we are obliged to use for the formula. The donor breast milk is somewhere in between. So it decreases the risk of feeding intolerance and NEC. And it's indicated for babies less than 32 weeks. There is always a consent should be obtained from parents or guardian prior giving DBM and even formula. For the body who asked me whether the formula. Where these babies, you should have always antenatal. And if you don't have an antenatal consult, then you have to talk with parent to start feeding if there is no EBM right away. Now, when the DBM is giving to an endpoint. When is that endpoint? When the baby is on full feed for at least 48 hours. And when the goal weight is reached, which is 1500 grams, and sometimes people say 1800 grams. And when the goal gestation is reached, which is 34 weeks. Sometimes the weaning of donor breast milk can be before that if we have the DBM. So the weaning is not must. The weaning at 1500 grams or 1800 grams only if the EBM is not available. So EBM is the priority and the DBM is the next, and then the formula. That is from evidence point of view. Now, when we transition from DBM to formula at age of 1500, at age of 34 weeks, or at weight of 15 or 1800 grams, it should be very slow. Do you guys hear me? Is my voice clear?
Yes.
Okay. Great. So how we transition from DBM to EBM? Usually what I do, if the baby achieve full feed for 48 hours, I start to remove 25%, and the 75% I usually make it EBM, and if the EBM is not enough, I add the formula. And the next day I do 50-50, and the third day I do 25-75 EBM and formula, and the fourth day I will be fully on the EBM or on the formula. Now we know that the composition of the human milk is optimum for growth and for nutritional values and for metabolic and minerals. There are many formulas in the and kindly mute yourself, Ya Abdullah Ahmed, Dr. Abdullah Ahmed. There are many other formulas like Enfamil Premature or Made Johnson that's made, or there are two types, and there's of higher protein, and there are many other formulas that are trying to mimic the breast milk, but despite all they can do, there is always variation from the optimal nutritional values for EBM. And these formulas are of different purposes. Some of them that standard 20 kilocalories, some of them that are premature 24 kilocalories, some of them are very high caloric formulas, and some of them are discharge formulas, which is 22 kilocal per ounce. Now we know that the whey predominant will have better taurine amino acid, and we know that taurine are better tolerated and produce more normal plasma amino acid profile than the casein predominant protein. We know that the mixture of carbohydrate between 40 to 50 lactose and 50 to 60 glucose polymers will compensate the need for preterm infant deficiency of lactase, and inability to tolerate lactose. And therefore, adding glucose polymers will minimize that problem. We know we need to do a kind of fat mixture with around 40 to 50 of middle chain triglyceride to compensate for the limited pancreatic lipase secretion in newborn babies, medium chain triglyceride. And therefore 50 to 60% of the feed should be, or of the milk that is going to the baby, should be actually long chain triglyceride. We need a higher concentration of protein, vitamins, mineral, electrolyte to meet the increased need associated with rapid growth and limited fluid tolerance. Now, how we give tube? Now, we've talked about the minimal enteral feed, and we've talked about fortification, and we talk about EBM. Now, how we give the tube feeding? Now, is it OGT or is it NGT? Now, we know that OGT has better tolerance and easy to fix, while OGT have some difficulty in fixing and is less tolerated. Otherwise, it depends on the preference of the unit. So how we start? We start depending on the weight. So we can start somewhere between 10 to 40 ml per kg per day on the first feed. So if the weight is 1 kilo, we give 10. If the weight, let's say, is 2 kilo, we give 40 per kg per day divided by 8, and then you give it. And then you can increase the feed every 12 hours, also by half of that feed, almost of that starting date. And remember, always when you start with every 4 hours. And when you stay on that level for 24 hours. And when you advance, based on individual need, the abdominal distension, the tolerance, the desaturation, the poop, the bowel motion, and so on, and of course the weight, and the TFI, the fluid intake that you need that day. And remember, once you reach 70% of the TFI as feed, you can stop the lipid if you are giving parenteral nutrition. And once you achieve 120 ml per kg per day, even if your TFI is 150 or 160, you can stop TPN. And at that point, you can omit the rest without IV fluid, depending if you have line or you don't have line, and if your line is good or not good, and if you have sepsis and you need to remove the line. So if, for example, I have no line and I reach 120, I omit the rest. I can wait until the baby reach 24 to 48 hours until he or she reach 2150 ml per kg per day. And remember, when you start feed and you want to give MEF, it should be either EBM or DBM, but it should not be high caloric, 24 or 30 or 27. The minimal enteral feed or tophic feed or gut priming should be always 20 kilocal formula. Once you start, you finish your MEF, which is somewhere between 1 to 5 days, then you can switch your EBM, DBM, or PREM 24. Once you optimize the feed in first 24 hours, everything, you can give the feed every 2 hours, every 3 hours, depending on your weight and your gestation and your appropriate corrected gestational age. Now, how you give the flow, how fast the flow should be given. Now, the flow can be gavage feeding, and gavage feeding mean using gravity. And the feed should go to the baby in less than 20 minutes. However, it should not be also fast, because I saw some of the unit, they give fast feeding called gavage, they put the tube, the feeding goes right away. These babies has limited perception pressure. The perception pressure is the percentage of your stomach dilatation when you eat, when you receive the milk. And this perception pressure should be less than 30% of your actual stomach size. So if you give the feeding very fast, you get vomiting. That is not feeding intolerance. That is not GIT problem. That's iatrogenic vomiting. So you need to be careful when you give the feed not to give it fast. It should not, if it's less than 20 ml, it should not be more than 1 ml per minute. If you reach 20, you give it 1 ml per minute. If you reach 30 ml, you give it 1.5 per ml per minute. If you reach 40, then you're giving it 2 ml per minute. But if you are 10, you should give it 0.5 per minute. If you are 5, then you should give it a quarter ml per minute, and so on. You don't need. Now, how you manage that? You have to have a watch, the nurse, look at the watch, time it, and then increase and decrease the column of the syringe containing the milk up and side to increase or decrease the flow depending on the volume of the milk that she's looking at. And if you want to give more than 20 ml, 2 ml, then you probably can go to the baby can tolerate 2 ml a minute, and you're giving, for example, 40, and you're giving 2 ml per minute, and you need to give more, then probably the baby can tolerate feeding a little bit faster. When you give the feeding, you can give it Q2, Q3, Q4 as a gavage. That wouldn't be a problem. Now, if you want to give more than 2 ml and the baby is not tolerating, you need to give the feeding over 30 minutes. Now, if you reach that, then that is not a bolus, that is not a gavage, that's called intermittent continuous. So you're not giving it a continuous, but you are giving it a continuous, but there is a rest period. So it's intermittent continuous. So the intermittent continuous feed is more than 20 minutes, but less than continuous. So what is continuous? Even if you are giving 2 hours feed and the feeding is 20 ml, then it's 20 ml over 2 hours. But if you want to give that, if you want to give it over 1 hour, 20 ml over 1 hour, and you have 1 hour rest, then that is intermittent continuous. If you're giving every 3 hours and you're feeding over 1 hour, that is intermittent continuous. And by then you need an infusion pump to give the milk, not by gavage. While the continuous feed is a continuous feed. Now, the continuous feed is very good because the perception pressure will not be affected. However, it's not physiological. When the baby is on continuous feed, the circadian rhythm, the sleep-wakefulness cycle for normal neurophysiological development will be affected. The peaceful stimuli of the feeding versus noxious stimuli of not feeding will be affected. So despite it's good for perception pressure, despite it's good for tolerance, but remember to switch to intermittent continuous whenever you can, even if it's 15 minutes break or a 30 minutes break, and usually move slowly. So don't go from continuous to bolus. So if you are continuous over 3 hours, then I will move, like, for example, 1 hour off, 2 hours on, and then 1 hour and a half, 1 hour off, and 1 hour on, 2 hours off, until I go to the bolus feed, which is 20 minutes of feeding. So what are the food for the newborns? It can be human milk, and the human milk can be giving direct, can be giving as a UPM, and can be giving as a DPM. We can give a preterm formula, we can give term formula, we can give specialized formula, we can fortify any of these, and we can add supplements. So these are usually the food, the meal of a baby. What are the specialized formula? Now there should be an act to trim the use and the composition of any specialized formula. You cannot allow the milk companies to do whatever they want. What are the caloric energy enhanced feeding? Many ill-term and even a preterm baby, they are facing lots of physical and chemical challenges during their course in an ICU. And in that period, they need more nutrition. And also they need to catch up their mate. So they are growing very fast. So they need to achieve an optimal growth rate. And therefore, they need a special calories to improve that. So how we can improve the calories requirement of a preterm babies? We can give human milk fortifier, and it will give us up to 4 kilocalories extra for each ounce, or 28 ml. We can give liquid donor human milk fortifier. Whenever you fortify your milk, you should targeting, because you know that the term formula give you a 20 kilocal formula, you need to target somewhere between 24 to 30 kilocal per ounce, which means not more than 1 kilocal per ml. You should not exceed, when you fortify, when you enrich your meal to a newborn baby, you should not reach more than 1 kilocal per ml. And the reason the bowel cannot tolerate that. When you give fortification, not only the content will increase, but you will give more calories. When you fortify, remember the mineral will stay the same. And therefore, you need to check your electrolytes and add, if you want, such as sodium, potassium, calcium. These need to be a supplement. These are not a fortification. Sometimes, if you are limited, there is now a cream, and we know that the skin of preterm baby, especially those below 1500 grams, are not mature, and the corneum last layer is not mature, so the absorption is very good, and also the oozing are very high. So putting a cream of breast milk can give us more calories, can protect the skin, and can prevent infection. If the calories are enough, but the protein is enough, and that evidence from some metabolic acidosis on the blood gas, then you need add some protein, such as plant protein or milk powder, Infacare powder to the milk. And you can reach, even if you are not on parenteral nutrition, you can reach up to 45 grams per kg per day from adding protein. Now, whenever you want to increase the calories, you first need to maximize your TFI, if the baby and the condition of the baby allows you. You can add calories by adding oil, such as medium chain triglyceride. And by adding all this, you can achieve your target, which is somewhere between 24 to 30 kilocal per ounce, or per 28 to 30 ml. When you want to increase the calories intake more than 20 kilocalories, first achieve 24. Once you achieve the 24 to 48 hours, then think of going up to 26 to 30, and you should never exceed 30 kilocal per ounce. What about enriching term babies when they need for a certain condition, such as heart failure, or they are sick, or when they are low weight for gestation? We can add infant formula powder. We can again add MCT. We can add corn oil. We can add carbohydrate. And we can increase the calories to 2 to 3 kilocal per ounce, because you don't need to increase in term baby more than that. And again, in a term baby, you should never exceed 30 kilocal per ounce. When you need to move from term formula or 20 kilocal formula, whether it's a EBM, TBM, or a formula, you remember to adjust it slowly and watching the tolerance of the baby. Remember, when you have poor growth and you are on an EBM, remember the hind milk, because moms will stop expressing and they don't reach to the hind milk, which is very rich with protein. And so sometime, if you have the facility to examine the milk and see if it's a fore milk or a hind milk, that also will help. If you don't have, then you need to watch the mother when they are expressing the milk. Do you guys hear me?
Yes.
Okay, great. So sometime you can, if you don't have fortifiers and you don't have supplements, you can concentrate your feeding. However, this is very dangerous. You need to monitor the ash cloud on the kidney, and you need to look at your bowels, monitor the stool, and monitor the abdominal girth, and monitor your electrolytes, and also you might need to monitor your blood gas. So again, what is the further supplement? It can be fat, it can be carbohydrate, it can be protein. And these are some example of it. Doesn't mean that I'm advertising for this product. These are just an example. So I'm not gonna go through it, but there is a recording. You can pause the recording and look at them. The feeding method should be based on individual base, weight, gestation and corrected gestational age, and the tolerance. Remember that respiratory support is not a contraindication of feeding. I already talked about that, about nasogastric tube or orogastric tube, and we've talked that orogastric tube may be a little more difficult to fix it because of the secretion, and nasal is more stabilized. But it depends on who's candidate that need feeding tube now. Well, any babies who have no swallow, and even if they have the swallowing, they have deglutition, or in other way they are swallowing, but also they can coordinate between breathing and feeding, and they won't develop apnea and desaturation during feeding. And usually these babies, they have the deglutition is they are more than 34 weeks. However, even after 34 weeks, you have babies that they don't have proper deglutition, such as when you have encephalopathy or hypotonia or maxillofacial abnormalities, such as receding chin. And now, when we do a nasogastric tube or orogastric tube, are we giving bolus or giving intermittent feeding? We've talked about this, so I'm going to pass. But these are an example of how to do intermittent, which is more than 20 minutes, but less than 90 minutes, less than full feed. So, for example, 30 minutes over 120, or a half hour on, 90 minutes off, and so on. These are examples how to do intermittent feeding. There is no superiority of any way of intermittent feeding, but it depends on your baby tolerance and your observation. I usually initiate the feeding as a bolus, and I usually deliver it when it's MEF. I deliver it every 4 hours, and then I move every 4 hours, and if every 3 hours, and then the optimum for babies to tolerate and prevent iatrogenic vomiting, I might do it every 2 hours. And if that's not helping, then I move from bolus to intermittent. And if that's not helping, I do continuous feeding. Now, the other feeding other than NGT and OGT is transpyloric feeding. Now, I'm going to pass this because this needs a special feeding tube, needing the tube to be freezed, needs special radiological technique, and you need special procedure to cannulate the pylorus. And I know many of you won't have this facility, but there is candidate for babies. They can do transpyloric if they are not suitable for gastrostomy tube. So I'm going to pass this. So how we transition between bottle and formula? Well, it's a gradual. So whenever we are on a NGT or OGT or transpyloric, the first we do dry. We can do dry feeding, or encourage non-nutritive attempts. Once we see that the baby is sucking and tolerating for a good period of time, with the vital signs are stable, then when the baby achieves 34 weeks, then I would try nutritive sucking. The reason for non-nutritive sucking is to facilitate milk production of the mother, increasing the likelihood that the baby can achieve breastfeeding before going home. Well, the candidate for non-nutritive sucking is 34 weeks, and they have deglutition, and their respiratory rate is less than 60. And after that, we can try the nutritive sucking. Now, sometimes we cannot achieve. We don't have transpyloric. We don't have. We cannot keep the baby on feeding tube. Then sometimes we need a gastrostomy, and especially those have neurological impairment and they cannot suck enough amount of milk by the breast, and they are not growing, and we cannot achieve or keep the feeding tube for various reasons, such as respiratory problem, or the parent are not trained and they have multiple loss of weight and growth restrictions, sometimes dehydration, then a gastrostomy tube is indicated. Now, there is special situation when you need a special formula, such as when you have cow's milk allergy. You need to use either partial or completely hydrolyzed formula. In bronchopulmonary dysplasia, you need limited fluid, high sodium, high calories. In biliary atresia, you need semi-elemental and you need more long-chain triglyceride. In chylothorax, again, you need long-chain triglyceride. And in congestive heart failure, you need high caloric formula, less sodium, less fluid. In cystic fibrosis, you need semi-elemental containing more long chain, and you can use the standard formula and supplement it with pancreatic enzyme. However, in galactosemia, need soy-based protein formula, no lactase. In gastroesophageal reflux, you need standard formula or some formula that's used for thick and used for reflux. In hepatic insufficiency, you need semi-elemental with long-chain triglyceride. In lactose intolerance, you need lactose-free formula. In lymphatic anomalies, such as when you have hydrops fetalis, or you have chylothorax, or you have intestinal lymphangiectasia, you need significantly low long-chain triglyceride with high medium-chain triglyceride. In necrotizing enterocolitis, well, you need EBM, DBM, but you can use Britain formula, and sometimes you need semi-elemental. In renal insufficiency, we use the standard, but we minimize the intake. Now the supplements. So we need some time to supplement iron, and the baby by standard should receive 2 to 4 milligram per kg per day after 2 weeks of life. All the milk should be fortified, all the premature formula should be fortified with iron, and the recommendation is somewhere 2 to 4 milligram per kg per day. Sometime you need to increase, you need to start 2 milliequivalent and increase it more and more, and sometime you need more than 4. But remember, when you give 2 to 4 milligram per kg per day, you need to supplement. Those who did not receive blood transfusion, you need to supplement for phlebotomy. And when you start iron on day 14, remember the days when they are not on iron. The iron supplementation of a preterm baby should be up to 12 months of age. So if you are giving 150 ml per kg per day, the supplementation you are giving around between 2 to 3 milligram per kg per day. Low iron formula are not recommending for term and preterm baby unless there is specific situation. Now, I used to start iron at age of 21 days, but some people start at age of 14 days. It's important, the vitamin E, however, is an important antioxidant, and therefore it's important to minimize and maybe prevent the chronic lung disease. And the recommendation is to give somewhere between 2.2 to 12 international units per kg per day of vitamin E. Remember that to not initialize the iron unless the baby is on full feed. Otherwise, the iron will come from TPN, from blood transfusion, and others. Other immunonutritive, I don't think there is a solid evidence, such as glutamine and arginine, or other additives such as HMO in the milk. I don't, up to this point, the evidence are very weak, so I'm gonna pass them. The vitamin D, vitamin A, inositol, and long-chain polysaturated fatty acid are questionable to use. However, some people use it as a treatment or as a prevention or minimizing the chronic lung disease. I'm going to pause this. I already talked about this. Now I'm going to talk about special situations such as gastroesophageal reflux. The problem of gastroesophageal reflux is subjectivity in its diagnosis. So if we put a probe, a pH probe, and measure, you'll see that all the preterm babies will have regurg. But who's actually clinically significant and who's not significant is very difficult to decide. Despite they have lots of pH probe gastroesophageal reflux, but most of them are asymptomatic. How we introduce milk to gastroesophageal reflux? Now, before how we introduce, how we diagnose it, it's a clinical. Is there is a respiratory problem? Is there is this destabilization of the vital signs? Are we not tolerating the feed of? Are we have excessive crying? Do we have difficult to contain the baby, and so on? From these clinical points, you can decide whether these gastroesophageal reflux are actually clinically significant or not, because all the investigation is not confirmatory. So once we introduce the feeding, you will have the feeding intolerance and you will have vomiting. And again, most of these vomiting either because of the way the milk is flow, bolus, intermittent or continuous, and the constituent of milk, and the perception pressure. So there is lots of babies who vomit not because they have reflux, but because the way we feed them. Remember that these babies might have intestinal dysmotility, and because of prematurity, and thus contribute to their feeding intolerance, not the gastroesophageal reflux. And please treat gastroesophageal reflux by changing the way you feed, not domperidone, not Gaviscon, not PPI, not any type of PPI, whether it's whatever you're using in the unit of these PPI or anti-H2. I really hate them because they have nothing to do with other than you're increasing the risk of getting the bowel thicker and thicker, and you might have a risk of pyloric stenosis. Domperidone, Gaviscon, and PPI are of no use in preterm babies. Even in surgery, I know the surgeon love it, I know some of you love it, but they have no indication other than harming the baby. When you do enterostomy, the PPI only work on the stomach and the duodenum. It has nothing to do with the neck. It has nothing to do with the bowel, unless you have foreign gastric implant in the bowel, like Meckel diverticulum. So omeprazole has nothing to do with neck, and omeprazole has nothing to do on babies with pediatric surgery, unless the surgery in the duodenum or in the stomach, and you have gastritis. And when you use them for a duration of time, not all give them open. So even if there is article about this, believe me, they are of no benefit and they are doing harm, not benefit. So when you have gastroesophageal reflux, please modify the way you feed the baby, the type of the milk and the way you give the feeding. Sometimes you need to hold back, decrease the feed, or even stop it for 1 or 2 days. Sometimes you need to go to continuous feed, despite it's not physiological, but you need to give continuous feed. Sometimes you need to remove the additives in nutrition, whether it's a fortifier or supplements. And as I said, sometimes you need to stop feeding. And sometimes when you resume feeding, start for continuous if you have a regurg. Once you transitions from continuous, you can switch back to bolus. When you transition to bolus, you can increase and decrease your pumping time depending on the tolerance. You might use specialized formula a little bit thick, or you can thicken the formula yourself by using starch. When you use that, you need to monitor your baby for response. If you have repeated episodes of emesis, when you're achieving full, consider pathological diseases. Ultrasound and X-ray might help. Remember that preterm babies has poor perception pressure. And that's the reason for vomiting, not because he has gastritis and he needs omeprazole. Domperidone should not be giving any baby below 2 years of age. Omeprazole should not be given only for short period of duration unless there is gastritis or duodenitis. When you decide the bolus or intermittent continuous or continuous, remember your breathing pattern, your ABDs, and your respiratory status. Always remember when you achieve that to optimize your growth. Sometimes you need to change your therapeutic ways of giving the feeding. When there is respiratory compromise, when there is apneas, when there is growth restriction. So what you do, how you change your therapeutic options? Positioning and repositioning, moving the baby to different positions, especially making the upper part higher. Maybe you can try prone position or right side up. Changing your feeding intervals, 3 hours, you make it 2 hours. That might help. Gavage, you might change it to infusion pump. Infusion pump, you might change it to gavage. Monitoring apneas with the pH, because the baby might have central apnea, not feeding apnea, and the feeding apnea causing the regurg, not the other way around. The motility, the promotion of motility agents are not indicated in neonatology. They are, especially the erythromycin and clarithromycin, they are of no use in neonatology because they don't treat the pathological problem, the prematurity problem of the baby. Now, so if you can see that gastroesophageal reflux has nothing to do with medications. It's just a physiological development of the GI and the way we give the feed and the rate of feeding. No medications for gastroesophageal reflux. Unless you have evidence of gastritis or esophagitis or duodenitis. So what about neck? Now, baby with neck need lots of nutritional support because the bowels are sick and there is lots of sloughing and edema and death tissue, and these need to be compensated. So in acute phase, there is no feeding, you need parenteral nutrition. Once you decide to go, now I remember in 2000 where we were going to 21 days MPO. And antibiotics for neck. Then we moved to 14 days. And now we moved then to 10 days. And now people doing 7 days. And some people doing 5 to 7 days this year. Because of the importance of resuming feed and prevention of starvation in enteropathy. However, remember the gut priming this. And that's the indication of the gut priming here, not giving the minimal enteral feed during the disease process. Now this depends on the situation and the grading of your neck. So usually the neck takes between 5 to 14 days depending on the situation. And that period is baby without feed and need parenteral nutrition. How we initiate? If the baby clinically stable and we pass 5 days, no neck should be stay without feeding more than 14 days. And if the baby is not tolerating, then probably you have a complication of neck such as stricture. We generally start between 10-20 ml as a gift as minimal enteral feed. We prefer EPM, and if there is no EPM, it's the DPM. And I think DPM here is a treatment, not a feeding, and you should really work on that to enforce the DPM using a NEC baby. If we don't have, we can use elemental-based formula when we resume feeding in NEC patient. If it's a premature baby and you want to resume, you might think, and you don't have elemental, you might think of giving 20 kilocal formula instead of the 24 kilocal. Do not start 24 kilocal in a NEC baby. The feeding should be advanced slowly, and the advance should be somewhere between 10 to 20 ml per kg per day. And you can do that advance. I usually do it in the first, after first successful MEF, I do it every 48 hours in the first week, and then I move to every 24 hours increment. The increment over 24 hours, but you can divide it in 2 phases every 12 hours, and sometimes you can divide it into 4 phases, so you can do the increment every 6 hours. You might need to back off if the tolerance is not good, and you might need to pause the increment sometime. Once you reach 70 ml per kg per day of feed, stop lipid. Once you reach 120, then stop TBN. Now you need to decide whether to give that as a fluid. The rest, if the total feed is 150, that 30 ml per kg per day, you can give it, you can omit it, but you might lose weight, or you can give it as fluid or dextrose with electrolyte. Please do not aspirate gastric residuals. These are very important nutritional values. The only reason for aspirating gastric residuals is to check the placement, the correct placement of the feeding tube, and then put them back, even if they are bad color, even if they are blood. So if you decide even with blood, such as you have cow milk, you have to put it back, because blood have very good nutrition. You don't need to take it, it has iron. So aspirating, unless you have obstruction and you have if you have respiratory problem, you don't need to, unless you have specific situations such as gastroesophageal. And I'm not going to talk about gastroesophageal today for many reasons, because it's a long topic. But if you don't have that problem, you don't need to discard the stomach residuals, and you don't need to, and you need to encourage nurses not to doing that. Only if the nurse see the milk is coming or the gastric smelling, then it's good, you put it back. Now we say, what about if the baby if the baby will vomit? So once the baby vomit, that you know there is a feeding, but taking the milk from there is no point, even if it's not good color. So, what is the sign of feeding intolerance? Not gastric residuals. It's emesis, abdominal distension, apneas, hypotonia. At that point, you can reduce the volume, you can decrease the rate of flow, and you can maximize your duration of action. Sometimes if you have NEC, you might need to do a contrast study, or if you have another standard pathology, you might need to do a contrast study to see if there is some kind of complication such as stricture. Enterostomy sometimes need to be considered now, because when the surgeon decide that they do surgery for NEC, they do either PPL, primary peritoneal lavage, or they put Penrose, or sometimes they cut, or sometimes with enterostomy, sometimes they cut without, they do enterostomies without cut. When we have enterostomy, sometimes it's very difficult to achieve a good nutritional values. And depending on the length and the function of the upper part above the intrastomy, we can increase the feed. And it's very important to measure the electrolyte in the enterostomy output. And some people take from the upper and then inject it to the lower. And once you measure the electrolyte, you need to measure the electrolyte in the kidney. So to see if that the kidney is actually conserving this electrolyte. If you're losing the electrolyte in the kidney and in the enterostomy, you need either to inject it back or supplement the baby with extra. But if you want supplement from the mouth, why we don't put it back? It's better because it has lots of other stuff such as gut hormones. Of course, you know, when there is gastrostomy and there is treatment of neck, the villi might be affected, the length of the intestine might be affected, so you might have malabsorption. So you always need to consider that. And which part of the stomach are removed, and then which nutrient are absorbed in that segment, such as intrinsic factors or vitamin B12 or iron. You need always to remember that. And you need to remember what we call it the dumping syndrome, where the fluids stop moving. And also when you feed these babies, remember the growth. When you have enterostomies, you need to consider when to resume feeding. And again, remember, if you want to feed extra and the enterostomy sending you more, so why we don't inject it back to the distal opening? Better than giving the new food, because as I said, this might contain many stuff such as growth hormone, mucus, and any other, and even you might have some probiotics, beneficial bacteria. Even if you don't get a beneficial nutritional value from it, you might get electrolyte and fluid. Sometimes when you have enterostomy, feeding is not enough, so you need to supplement.
دكتور يحيى في مشكلة بالصوت.
My apology, my internet. Sorry about that. Do you guys hear me?
Yes, now. Screen and
Sorry,
voice.
sorry, I mean, the internet was not stable. So what are the challenges of infant of diabetic mother? Well, hypoglycemia. The second is vomiting. Now, why vomiting occurs in a baby with infant of diabetic mother? There are many reasons. First one, there is gastropathy and enteropathy due to load of the sugar in the bowel wall. Second, you might have some malformations such as DIOS or distal intestinal obstruction syndrome, such as microcolon or slow transition time. And also when baby is hypoglycemic, he also sometimes have TTN or RDS because they are more prone to that. So what we do in this situation, now the best thing we do is to have the dextrose available with nurse in form of glucogel. And the dose of glucogel is 200 milligram. And I know I was working very hard to bring it to Ministry of Health, and I think now you have it in the Ministry of Health. We should give 200 milligram, which is 0.2 gram per kg per dose. Nurse should not exceed more than 400 milligram per kg because of the osmolarity issues. And the nurse should use it freely. It should be used always for babies more than 35 weeks. However, sometimes you nurse gave more than 2 doses and you don't have IV line. So you have two choices, either to accept hypoglycemic encephalopathy or give more glucose. Even if baby is less than 35 weeks and you don't have option, then sometime you need to use it. If you need more than 2 doses, then a physician order need to be considered. Now, how we balance the feeding of infant of diabetic mother? Now we have two things. We have the feeding from one hand and we have the fluid from one hand. If you think that the feeding will be to full feed more than 3 days, then consider TBN. But if you think that the feeding will be achieved, full feed within 3 days, then D10 is okay. The second day with D10, you need to consider electrolytes. Now, once you reach 12.5, so if that D10 and you reach the maximum feeding, depending on the gestation and the day of postnatal life, then you might go to a concentration of D12.5 and D15. And if you need D15 more than 24 hours, then consider central line. Don't use only peripheral line. So, and then feeding from one side. Usually, I start by this total fluid. In term baby, I usually start with 60, then I go to 80, then 100, then 120, then 135. In infant of diabetic mother, I go by 10% more. So I start with 80, then 100, then 120, then 135, then 150, depending on the weight and the glucose intake and so on. Now, which weight I use? Remember that you have 3 types of weight. You have the birth weight, you have the current daily weight, and what is working weight. So if the baby edematous and it's not a must to use the birth weight. You can use less weight, or you can increase your weight, the working weight. So you need also to consider that. So consider the weight and consider the TFI, which TFI you will start with and how you will increase your TFI daily. And then consider your sugar level. So if your sugar level less than 7.1 and you are less than 72 hours of age, then you need to give bolus, and you need to go up with your D10 and go down with your fluid by feeding 10% of your feeding by 10%. If you are somewhere between 1.6, 1.7 and 2.6, you don't need bolus, but you need also to go up by 10% with your D10 and go down by 10% with your feeding from the TFI. Now, if you are between 2.7 and 3.3, and remember, this is millimole per kg, if you are between 2.7 and 3.3 and you are less than 72 hours, then you don't need to do any change. If you are more than 3.3, then you need to go up with your feeding by 10% and go down by your TFI by 10%. Now, consider the feeding every 3 hours, but If the baby is still hypoglycemic before next feeding, you can do it every 2 hours. And if that's not enough, you can do it at intermittent continuous. Once you achieve 3 readings and you are full feed, you can switch to direct breastfeeding. Or, you can always use whatever milk you like, EPM, DPM, or 20 kilocal formula. And sometimes you need to consider 24 kilocal in certain situations. Now, you need to remember that the maximum sugar load should be 15 milligram per kg per minute. And if you need more than that, whatever the way you are giving, whether central line or peripheral line or feeding, then consider medications. And please, steroid is not indicated. I don't know from where this steroid idea came from. People putting baby hypoglycemic on prednisolone and sending the baby on. That is not, the practice said, the evidence said, if you are more than 15 milligram per kg per minute, and you are more than 24 hours on that, consider hydrocortisone for 24 to 48 hours. However, you have more safe medications such as glucagon. So you can give a glucagon boluses, 0.1 milligram per kg. And then if you need more than 4 doses per day, you can go continuous glucagon. The best, once you cannot do that unless you are more than 3 days of life. And if you are more than 3 days of life and your sugar is less than 2.6 or less than 1.7, you need to send a critical sample, which mean glucose level, which mean ketones such as hydroxybutyrate in the serum, alpha hydroxybutyrate, or ketoacetic acid in the urine as a ketone in the urine, pH, insulin level, cortisol level, growth hormone. And if your insulin is high, then this is hyperinsulinemic hypoglycemia, and this is either temporary or permanent. At that point, you need to consider the medication, such as glucagon or diazoxide. And remember, the diazoxide is superior to octreotide. Despite both of them, they cause pulmonary hypertension, but especially octreotide. You need to do an echo before you start it. Now, when you have anemia, I'm going to pause this because I already talked about iron, and I've also talked about this. So I think I am finished, and I can take questions if you guys have any question.
Yes, hello, Dr. Yahya. Thank you very much for the lecture. I have received one question from Dr. Ahmad. It's saying, what is the indication to go for syringe, not gavage feeding? Is it the age or the weight or the amount of feed?
No, the feeding tolerance, neither. The feeding tolerance, if you are giving bolus feed and the baby is tolerating the feed, and you reach more than 2 ml per minute, which means 40 ml, your baby can go direct feeding. The problem happened that babies start vomiting, and right away people start domperidone or omeprazole or Gaviscon or whatever they want. And most of the time is either due to gastroesophageal reflux or iatrogenic. Baby has no reflux. It's just the perception pressure of the stomach cannot tolerate that rate of flow of the milk. So in that situation, you need to consider your intermittent continuous feeding. The other is continuous feeding. The baby have no store and can go hypoglycemia. The other indication of continuous intermittent is when the bowel are sick and you need to give them rest. But always remember that bolus feed 20 minutes is the physiological. Is the feeding that the baby will sleep with it. Is the feeding that will have the circadian rhythm. Is the feeding that will get a better neurophysiological development. Imagine that you want to sleep and I give you food. I force you food. That's the problem of non-bolus feed. But sometimes you are forced to do so. I can tell you about now well, I'm estimating, I have no evidence, but about 80% of these vomiting and feeding intolerance we created, and then we start to treat it by domperidone and Gaviscon and omeprazole. And I hope I answered your question. Any more questions?
Yes, Dr. Yahya, one question. Why you said iron supplement to start at age of 2 weeks, not 3 weeks?
No, I said I start at 3 weeks, but some people start at 2 weeks. And should not be start unless you have a good vitamin E, because they are oxidants. And when you start and consider the dose, that the requirement is 2 to 3 milligram per kg per day. But consider the phlebotomy loss and consider the duration that the baby did not receive. So let's say the baby was not without iron over 21 days. So 21 days times 3 grams or 3 milligrams per kg per day of iron, that will be like 63 milligram. So if you want to replace that over 1 month, then you need to give like 3 milligram per kg per day as a maintenance and 4.5, I mean 1.5 extra to replace whatever baby missed from that days. And also consider that how much iron lost from phlebotomy. So you need to have a registry or a manual, how much phlebotomy you do every day, and then count how much iron you lost, and then use, otherwise the baby will not grow. And then you need to transfuse, and you get transfusion problem. So the decision to start iron is usually where, when I was started neonatology, it was 28 days, but people moved 21 days, and I used that 21 days, but some people start at 14 days of life. They have the facility to make sure that the baby is already on vitamin E. Okay.
There is a question from Dr. Muhammad Hamid. Thank you for the lecture, very informative. You mentioned glucagon can only be used after day of life 3. Why is that?
No, it can only be used, it must be used. Well, it can be used before, but it must be used after 3 days. It can be used before. And the reason for that is most of your hypoglycemia is because of the store, or because you have high insulin at the beginning. So when the baby of infant of diabetic mother, or if the baby is big, and baby is big because you have more insulin and more sugar. So when the placenta is cut, the insulin of the baby is okay and very sensitive to insulin. So once the placenta cut, the sugar drop down. So what you need to go to bring the dextrose back to where it was until the insulin calm down. So that and problem of storage usually will resolve within 3 days. If the hypoglycemia continue after 3 days, then it is a persistent hypoglycemia. Then it's mostly due to hyperinsulinic. It can be temporary, it can be persistent. It can be necidioblastosis, for example. So you cannot insert glucagon and other medication, not only glucagon, unless you have 3 days past and you have a critical sample telling you. Otherwise, there is no point of starting glucagon if the insulin is okay. So what's the point? So glucagon and diazoxide and even octreotide is to antagonize the effect of insulin. Now, if you don't have facility to measure insulin, you need to give it a try. Just a trial. But first, you need to reach 15 milligram per kg per minute of glucose load before you consider these medications. There is no point of giving steroid, despite steroid have a side effect, hyperglycemia. Because the problem is either storage or sensitive insulin or hyperinsulin. All of them, steroid does not work on them. Now, why you give steroid is a temporary measure. So if you are giving 15 milligram per kg per day of a glucose load, and you don't have a reason to start medication, you might give steroid as a temporary, as a crisis management, give you a gap of 24 or 48 hours before you consider other treatment options.
طيب دكتور يحيى في question Dr. Chandra, thank you for the nice lecture. You have mentioned about mixing the feed 50% DEM and 50% formula. The question is there any risk of sepsis?
Well, first, the answer will be two phases or two parts. First, I didn't say that. I said you start on EBM, and if the EBM is not enough, you top it off with DBM. Once, if you are zero EBM for any reason, you give full DBM. And at that point, the DBM are very expensive. At that point, you need at some point to wean the baby from DBM. And to wean the weaning, you need to reach an end point. The gestation reached 34. The weight reached 1,500 grams, and some people stay until 1,800 grams. The baby is on full feed, and 48 hours passes on full feed. Now you need to take out the DBM. So first, I will add formula, but if I have EBM, then there's no need. There is no need to do that. But first, first day of weaning of DBM, I will give 25% formula, 75% DBM. Next day, I will give 50-50. Third day, I will give 75% formula, 25% DBM, and the following day will be full formula. Now, the second point of the question, what is the link between formula and sepsis? Well, we know when the baby is on formula have a risk of sepsis, not sepsis. But I don't think formula can cause sepsis unless the preparation of the formula, the way we prepare formula, can cause. Therefore, in an NICU, always we have to use a ready-made formula because the risk of causing sepsis or contamination of the formula will be eliminated by having ready-made formula. And that's the reason why we switched about like 12 years ago from preparing the formula in the unit to having a ready, and most of the companies now make it, is ready-made formula. But I don't see a link between formula and sepsis, but we know formula is a risk of sepsis because of contamination. But with using ready-made formula, the risk of contamination is high, and therefore you might cause sepsis.
Okay, thank you, Dr. Yahya. I have a question again from Dr. Muhammad. As you know that the glucagon storage in low birth weight infants is low. Do you use glucagon infusion to treat hyperinsulinemic hypoglycemia in low birth weight infants? What other
infusion? What do you mean by glucagon infusion?
This is the question. Glucagon infusion to treat hyperinsulinemic hypoglycemia in low birth weight infants. What are the other options? And what is the maximum GIR you use? This is a long question, doctor.
Okay, so to consider glucagon, you need three things. First, your baby passed 3 days, and now you have a definition of persistent hypoglycemia. Second, you need to have hyperinsulinemic hypoglycemia. So either you test for that or you suspect clinically if you don't have facility. So that's the second thing. Third thing, you should give enough glucose load. And that enough glucose load, more than 15 grams per kg per day. Now, what is the maximum? For peripheral IV, the maximum is 12.5. However, you can give D15 for a short period of time. If you need more than D15, you need a central line. If you have a central line, you can give as much as you want. You can give up to D50, 50, whatever the amount. But if you need more than D15, more than 15 milligrams per kg per day, and you have more than 3 days, and you have possibility of hyperinsulinemia, whether you tested it or if you don't have a test facility or suspecting it clinically, then you need to consider medication. Now you can use a steroid as a gap, bridging between your high glucose intake, which is more than 15 milligram per kg per minute, until you start your medications. That period of gapping should be 24 to 48 hours. After that, you need to consider medications. What is the safest medication? Is the glucagon. The glucagon is IM or IV. So once you check the glucose level and you are needing more than 15 milligram per kg per minute and still low, consider a glucagon dose, bolus, 1 dose. And then give an order to give it as a PRN every 4 times a day. If you need 4 times a day of glucagon, then consider infusion. Now, why you do that? Because other medications have a risk of pulmonary hypertension, which is the octreotide and the diazoxide. The octreotide is superior because the diazoxide is superior because it has less pulmonary hypertension, one, and second, it's an oral. Although there is an evidence that might cause some GI blood, I mean, bloody stool, some of the unit, there is no evidence. So even both diazoxide and especially octreotide, if you need to consider it, you need to do a functional echo. So I don't know if I answered the question because I was really don't understand exactly the why they're asking question. You're probably confused. But glucagon infusion are considered when the baby need more than 4 doses of glucagon bolus, when the baby is more than 3 days, when there is risk of hyperinsulinemia, especially if it's measured one, and you don't have yet the diazoxide ready because you need to test and you're not sure you actually need the diazoxide because diazoxide should be continuous, not as a crisis management, while the glucagon is can be as a crisis management to prevent hypoglycemic episodes.
Okay, thank you, Dr. Yahya. I think Dr. Muhammad, your questions has got the answer. Question, Dr. Sundos, what is the best oil you can add to formula to increase the calories to reach 30 kilocalorie per 30 ml in patient with chronic lung disease?
Well, first, you don't need to depend only on MC and on glucose, on fat. You can add protein, glucose, and MCT. MCT, you can give up to 4 grams per kg per day increment of fat. So the fat that you use, I recommend MCT. Which MCT? Now you need to decide. It should be MCT. It should not be olive oil, and it should not be mineral oil. It should be MCT. It should not be long chain. It should be MCT because have more energy. It gives you 9 per 1 gram. It gives you 9 kilocalories. So if you're giving 4 grams per day per kg per day and the weight, let's say 2, that's 8 grams times 9. That is, so you're probably giving per day 18 kilocalories per kg per day. And if you add the feeding, if you are giving, for example, 24 kilocal per kg per day every 3 hours, and if you divide that, 18, that is 36 divided by 8, that is each feed you're getting 3 kilocalories. So if you're giving 24, that is 27 kilocalories per ounce. And then you need to consider other, such as glucose, and you need also to give more protein. Because once you need more calories, you need more protein. Otherwise, the body starts to use protein as calories, and you get metabolic acidosis, and you get metabolic decompensation. So once you consider fat, you need to consider, you need to keep the balance between the fat, carbohydrate, and protein.
Doctor, there's a question about what is the right time to start feeding for a baby who is cooled, HIE, under hypothermic, therapeutic hypothermia?
Oh, okay. Well, it should start when the bowels are safe. So when there is no ischemia, the bowel, you need to make sure that there is no ischemia and there is no hemodynamic decompensation. So how that? Baby should not be on inotropes, and the baby passes stool. There is no abdominal distension. There is no bloody stool. And there is no metabolic acidosis. So if you have all these, you can start. Even if you are cooling, you can start. So again, the baby should be hemodynamically stable. And the bowel should be healthy. And how you know that? Baby passes stool, no blood, no abdominal distension, and there is no metabolic acidosis. If you have facility of ultrasound, you can look at the peristalsis by ultrasound. And you can look at the Doppler of superior mesenteric artery, inferior mesenteric artery, and subplanchnic artery. Any more questions?
Doctor, there was a question about the ethical issues with the formula feed. I can't find it. Sorry, it was earlier. You remember?
I don't know what is the ethical issues, but the scenarios, usually you face is two scenarios. The first scenario is you have antenatal consult, and we're talking about babies who need formula, not a term babies. The term baby can wait. So usually we do antenatal consult, and we consider that the moms start to have express milk. Sometimes they can't. So that time we should consider formula. And if the situation allowed, we can consider DBM. And in both situations, informed written consent from the parent should be taken. Now, if the baby was very imminent and you don't have the luxury time to talk with parent antenatally, then you need to take consent from father, if available, to start formula. And if neither available, then you don't have anything other than waiting. No more questions? I can go?
Color of gastric residual. I think we talked about it, doctor.
Whatever the color of the gastric residuals, if it's not neck, and if it's not intestinal obstruction, put it back. Even if it's a blood, put it back. Blood has lots of nutrition and iron. There is no reason, there is no any solid reason to do gastric residuals, only to make sure a correct placement of feeding tube in the stomach. So if you have bile, then you just please check it by X-ray or, pull it back a little bit.
Thank you. Doctor, there's a question about, do you withdraw all the measurements of the critical sample in preterm also? I
Yes.
think he's about the critical sample. For
Absolutely. Absolutely. You need the critical sample in all babies. If it's more than 3 days. However, if more than 3 days, then you cannot give glucose load more than 15 milligram per kg per minute, then you probably it's not hyperinsulinic hypoglycemia. You are just not giving enough food to the baby to maintain the sugar. So these are conditions: 3 days, good glucose loads, and there is evidence it's hyperinsulinemia, whether it's a premature or it's a term baby.
Dr. Yahya, I have a question. What do you think about delaying the initiation of the feed in an extreme preterm in view of that the baby did not pass meconium yet?
Wrong. Feeding in preterm babies, even if it's 400 grams, should be started on labor. The earlier, the better. There is no indication baby might pass meconium after 48 hours. That's the normal physiological. Most, I would say 90% of not passing meconium is we don't see it. Maybe it happened during delivery. We don't know. So there is no reason. The normal physiological process, you need the bowel to move. And bowel to move, you need milk. So normal physiological timing of passing meconium is 24 to 38 hours. Does mean I have to wait 24 hours? No, of course not. What will happen if the baby die? Because it's high mortality. Now, if I am dying, I would prefer to die and I am not fasting. Why I should fast while I'm dying? I prefer to be like most of people who is executed, they will ask for a meal. So I don't see a point of keeping the baby fasting, even if the baby dying. And definitely a baby or preterm baby, they need milk to fight better.
Okay, thank you, Doctor. Again, Dr. Muhammad Hamid is again insisting on the same question about the critical sample. He's telling, but it is 3 ml.
You
Okay.
so you select like not, can you hear me? So for example, do you take all of it or do you prioritize, like select which come first? Like,
No,
for example,
so why you want not to take it? I just don't understand.
because usually it reaches about 3 ml in very small preterms, like 27 liters, and it's a big volume.
So first, I need to go back with you, and I want to decide why you want to take the sample. So you are now giving the baby a 15 milligram per kg per minute, and you have a central line, and 3 days passes.
True.
And you think that this baby have hyperinsulinemic hyperglycemia.
Yes.
Why? Why you're thinking this way? What's the reason? Because hyperinsulinemic hyperglycemia, there are either risk factors such as baby premature, but mom is diabetic, or baby have, for example, family history, or you do a critical sample and you find the reason. Now, if that's the situation, then take the 3 ml. I don't know why it's the 3 ml. It's way high. It's way less than 3 ml. Why 3 ml?
Okay. Well, it's usually 3 ml in our hospital.
Oh no, it's way
that's
none.
why
It shouldn't be like
it's
more
way
than
less.
But even if that's the situation, you know that the critical sample, it will be of the.
I know it's important. I know it's important, but do you prioritize?
But if you need to know that, if you give me time, you need to know that your critical sample is at the lower level of glucose level. So the critical sample should be taken at that point. So I would take it, and if the baby is anemic, I would give transfusion.
Okay, thank you. I totally agree with you. Thanks.
Yeah.
Doctor, question about HIV infected mothers and feeding. Dr. Chandra.
Okay.
How about HIV infected mothers feeding? That's the question.
I wish you are not in that situation, but you need to make a very judgment call here, and which one is which? Is the risk of HIV or the risk of cutting the breast milk? So if you are giving the mother prophylactic and you are watching, antiretroviral and giving to the mother, and you're watching your baby and you will following this baby, I don't see a point of preventing the breast milk. But if you think that you cannot give antiretrovirals to the mother and the risk of transferring the infection to the baby high, and if you cannot monitor the baby, then better to switch to formula. But I would say in most countries, breast milk should be continued. That would be my answer.
I think we are done with the questions.
Great.
I think we are done. Thank you very much, Dr. Yahya.
Thank you very much, everybody. Thank you for watching, and you will see this online, inshallah, on my YouTube channel if you want to watch it later. Thank you very much, and please enjoy the rest of your night, and wish you all the best.
Thanks a lot.
Bye-bye.